Hi, sir. Good morning.
Hi, good morning. That's Sandeep.
Yes, sir. Sir, within 2-3 minutes, sir, please. There is some technical issue.
Share now. This is the dimension. Okay. So cross करो. इसको मिलास करो. इसको cross करो. Resolution मोड. ये दिखा ना. डायग्राम को इसको escape करना. इसको देखो ना साइड में रखो.
ये सर.
हाँ. मैंने escape करना है तो डायग्राम दिखा रहा है. इसको escape करना.
हाँ, डायग्राम देखा तो मैं
इसको escape करना.
So good morning, sir. Sir, are you able to?
Yeah.
Sir, I'm Dr. Sandeep, sir. Surgical oncology resident, first year, Prince Ali Khan Hospital. I'm presenting a case of my patient is a 17-year-old boy residing in Jharkhand. Came to the oncology clinic with chief complaint of swelling in the left scrotum since 4 months. Patient was asymptomatic 4 months back, after which he noticed a swelling in the left scrotum, which was insidious in onset, started at a size of 1 into 1 centimeter, and gradually progressed to the present size, which is of double to the size, and it was not associated with pain and not increasing in size during cough or straining. And patient had consulted local surgeon for this left scrotal swelling in his hometown, for which he has taken him for surgery 15 days back, and scrotal exploration was done, and surgery was abandoned, and there is no operative notes there, sir. And prior to the surgery, there is no history of any swelling in the opposite side of the scrotum, and there is no history of trauma, no history of fever, or burning micturition or body ache, and there is no history of leg swelling, and no history of lump in the abdomen, and no history of swelling in the neck or axilla or the groin region, and there is no history of cough or chest pain or dyspnea, and there is no history of anorexia or generalized weakness or recent weight loss, and there is no history of breast enlargement, and there is no history of any comorbidities, and no history of any other illness, any other surgeries done in the past or the childhood, and he is unmarried, and he has no habits or addictions. His sleep is adequate, his bowel and bladder habits are normal, and there is no history of similar complaints or any other malignancy in the family. Coming to the general examination, he is conscious, coherent, and well oriented to time and place, and patient is afebrile, and ECOG performance score is 0, and BMI is 21.5 kg per meter square, and pulse is 84 beats per minute, regular rhythm, normovolemic, and blood pressure is 110 by 70 millimeters of Hg, left arm in supine position, and there is no pallor, no icterus, no cyanosis, no clubbing, and no pedal edema, and there is no palpable axillary or inguinal lymph nodes, no palpable axillary lymph nodes, and the left supraclavicular lymph nodes are not enlarged, and there is no evidence of gynecomastia. Coming to the local examination, after taking a proper informed consent in the presence of male chaperone, patient was examined in the proper exposure in a well-lit room, and patient examined in both supine and standing position. On inspection, the right scrotum and inguinal region appears normal, and the left scrotum shows single ovoid swelling of approximately 5 into 4 centimeters size, which is extending from the root to the base of the scrotum, and there is a loss of normal scrotal rugosities, and the transverse scrotal incision is seen, and skin of the swelling is normal, and which is a suture site which is healed well, and there is no sinuses or ulceration or any nodules, and the cough impulse is absent. On palpation, the right scrotum and inguinal region is normal. There is no local rise of temperature or tenderness in the left scrotum or the left inguinal region. Inspectory findings are confirmed, and surface is smooth, which is hard in consistency with well-defined margins, which is extending from the root to the base, root of the scrotum to the base, and the getting of the swelling is possible. And cord structures are felt normal, and testis is not separately palpable from the lesion. And there is a 1 into 1 centimeter superficial inguinal node palpable in the left inguinal region. And coming to the para-abdominal examination, abdomen is flat, umbilicus is central in position and inverted, and there is no visible lump or pulsations or peristalsis. There is no scars and dilated veins, and hernial orifices are normal, and all respective quadrants are moving equally with respiration, and there is no organomegaly, no organomegaly, no lump palpable, and no visible renal angle fullness, and spine does not show any visible abnormality. And respiratory system, cardiovascular system, and central nervous system is within normal limits. Coming to the summary, sir, he is a 17-year-old unmarried boy coming to the oncology OPD with complaining of left scrotal swelling, which he was operated 15 days back, and surgery was abandoned. And on examination, his ECOG performance score is 0, and he has a swelling in the left scrotal region, which is of size 5 into 4 centimeters, which is extending from the root to the base of the scrotum, which is the transverse scar is seen, which is healed well, and there is no nodules seen. And getting up the swelling is possible, and there is a hard lump. And my provisional diagnosis is a case of left testicular tumors.
Okay. Sandeep, what is the only positive findings on examinations that you have mentioned?
So one is left scrotal mass is palpable, which is of size 5 into 4 centimeters, which is hard in consistency, and getting above the swelling is there.
No, so you don't have to describe the other findings. If you say that it's a scrotal mass and you confirm that, that's fine. So that's one. There's a scrotal mass with with a scar on the scrotum. That's one. What else? Any other findings?
And left inguinal nodes are palpable, sir. One inguinal node is palpable, which is of 1 into 1 centimeter.
Okay, and you think that this is a suspicious, likely malignant, likely non-malignant node?
Sir, I felt that it might be a reactive node, or it might be a positive node also, sir. As a scrotal incision was given, it might be a positive node also, sir.
Okay, when was this scrotal incision given? How many weeks or months back?
2 weeks back, sir. Patient is having between 2 to 3 weeks.
Okay. And any other findings in the neck or?
No, sir. There was no supraclavicular node palpable, and there is no other node palpable anyways.
Okay, fine. How do you want to proceed with this, Sandeep?
So first I will do an ultrasound of the scrotum, sir, to see for whether it is a solid mass or a cystic mass, and to see the opposite side of the scrotum, whether it is normal or not, opposite cystis is normal or not, and whether I want to see whether it is a homogeneous mass or a heterogeneous mass, whether it is solid or a cystic, whether as I felt the inguinal node, so I want to check whether this inguinal node is on ultrasonography, whether it is looking malignant or not, and if malignant.
So see, there is a little difference over here. Now, whereas a sonography of the scrotum is something which is recommended as the initial evaluation of a scrotal mass, but this is something which should probably have been done when the initial surgery was planned.
Yes, sir.
And that is when the findings of it being a homogeneous or heterogeneous or solid or cystic would have carried more meaning.
Yes,
now you have a patient where you say that the surgery has been abandoned because they were told that this is possibly a malignant mass. I think over here the importance of sonography should be more focused towards the other testis.
Yes.
Right, because what are the things that you want to look for in the other testis and why?
So one is microlithiasis. I want to check for the microlithiasis, and I want to check for any other lesion in the opposite side of the testis, whether it is any other a cystic lesion or a solid lesion in the opposite side of the testis. Because he's an young boy, if opposite side of the lesion is opposite testis is also having a lesion, then I am more concerned.
How common is it to find a lesion on the other side?
So only about 1 to 3% of the cases we'll see a bilateral testicular tumor.
Okay. And how common is it, or what is the importance of microlithiasis that you mentioned?
Sir, it is a intratubular. It may lead to the intratubular germ cell neoplasia. It's a
Say when you did the sonography, your radiology colleague mentioned that there is microlithiasis on the other testis. So what do you want to do? Do you want some more information on that, or do you want to act upon it, or why do you want to know about this microlithiasis?
because there will be the increased risk in malignancy, sir.
Okay.
It is more than 3 to 5 mm. This thing.
So if the radiologist mentions that there is microlithiasis, what would you want to do?
I want to see the. I want to ask him the size, sir.
Okay, more than the size would be?
Whether it is homogeneous or heterogeneous.
No, these are microlithiasis. They are micro. It is very difficult to say whether they are homogeneous or heterogeneous, right? So if you have to, further kind of classify or further elaborate on these microlithiasis, it is based on the number that you see on a sonography probe field.
Okay.
Right. Typically, they are known as the starry sky appearance, which how you see it on the sonography. You could Google the images, and it actually looks like a starry sky appearance on the sonography. Now, the importance of microlithiasis is, more when you have serial follow-up scans and you know what is happening to the numbers of these microlithiasis units.
Yes.
While there is a lot of importance given to microlithiasis, thinking that there could be an associated intratubular germ cell neoplasia, or ITGCN as we say,
Yes.
they've been found that it's not as common to find these ITGCNs, and often it is very difficult to detect these ITGCNs also with these microlithiasis.
Yes.
When would you be more concerned about microlithiasis in the other testis, or the possibility of a tumor in the contralateral testis? You said it is hardly 1% of the times, but when is it that is going to, kind of ring a bell that this patient I should be more cautious about?
Altered echo structure or in the testis.
Yeah, of course. I mean, radiology. So that's one thing. Radiology, if you've got any equivocal or unequivocal findings, but anything to do with the patient, in which set of patient you want to be more vigilant about these contralateral?
If it is a positive family history, sir, one, and if there's a previous history of malignancy, one, in the testis, and if you have a positive family history.
Previous history means we already have one, the other testis has cancer, no? So there's.
If it is in an undescended testis.
If it's an undescended testis, then you won't be able to do the sonography over there. Yes, but undescended testis, of course, it's going to increase the.
Testis, if it is a.
Anybody else would want to take that question? So you have a patient who's got one-sided testicular cancer. You're worried about the other side. You're worried about looking for microlithiasis and other things. When do you want to really chase this microlithiasis or chase the possibility of having a contralateral testis?
If he has a low sperm count, sir.
Yes, that's one important thing. So what is it? Where does it all fall into?
So if it is a low spermatogenesis, there will be altered cellular changes.
Yeah. So we've got some answers in the chat box. Actually, I wasn't keeping a watch of that. Yeah. So Ramya mentions testicular dysgenesis. Yes, that's the thing I was looking for. So would anybody want to elaborate on what is this testicular dysgenesis syndrome? So essentially, it's a complex where oligo or azoospermia is there, along with hypogonadism or sometimes undescended testis, and infertility, of course, because of the oligo or azoospermia. So if you've got a patient who's got these components of testicular dysgenesis syndrome, and you've got one side already proven testicular cancer, then you would be very, very cautious about following on the other side. Right. And yeah, cryptorchidism, thanks for reminding that. So yeah, undescended testis, cryptorchidism, hypospadias, and oligoazoospermia, and consequent infertility. That's all comes under testicular dysgenesis syndrome. Right. So you've got a sonography of this patient. Let's say the sonography was largely normal, except for maybe some specks of calcification on the other testis. What else do you want to do in the evaluation?
I will do a serum tumor markers, sir.
Which ones?
Routine investigation, serum tumor markers, AFP, beta HCG, and LDH.
Okay.
These 3 tumor markers.
Okay.
Then I will do routine investigations, sir.
Like?
Normal blood investigations, complete blood picture.
Yeah, that's fine. But I mean, aren't you curious to know what is happening to this patient? So you could mention that you're going to do. He's a 17-year-old boy. You're not expecting him to have CKD or diabetes or hypertension and such things. I mean, those things will be all okay, right? So aren't you curious to know about what's happening with this patient? What is his disease stage? What is his disease volume? And
I want to do a CECT chest, abdomen, and pelvis, sir.
Okay, fine. And
I want to see whether any other nodes seen in the.
Yeah, so fine. So we know why you want to do a CT. So
yes.
Do we have the values of the tumor markers and the CT on this patient, or
yes,
maybe we can just
we have the
consider. So
his AFP is 1.39. Beta HCG is 0.0805.
Okay.
And LDH is elevated, sir, 1053 units per liter.
Okay, now based on these 3 findings, what all comes to your mind? What are you thinking of?
So AFP is normal. LDH is elevated 2 to 3 times. So mostly the disease burden, LDH only will tell the disease burden is more. We'll only
first tell about the disease, then we talk about the disease burden. No, what kind of disease are you expecting here?
So when AFP is normal, then will be most probably it's a pure seminoma, sir.
Let's go back, no?
Yes, yes. Sorry, sir.
Okay, so most probably it is a seminoma. Yeah, so you're right. Most probably if it's a testicular tumor, it's likely to be seminoma. And
beta HCG is normal, means mostly choriocarcinoma and all this ruled out.
Okay, so
and LDH is elevated, so I'm thinking that the disease burden will be the more, as LDH only represents a disease burden rather than a diagnosis.
Okay, fine. Now, say this beta HCG was 15,000 and the AFP was 2,000 and the LDH was the same, 1,053.
Then most
I'll repeat: beta HCG of 15,000, alpha fetoprotein of 2,000, and LDH of 1,053.
Most probably it might be a choriocarcinoma, sir. Or a mixed germ cell tumor.
Okay.
Or a choriocarcinoma.
Yeah, so you would say that this then it comes more in favor of a non-somatomatous germ cell tumor and most likely a choriocarcinoma.
Yes,
the possibility of mixed is always there. That's more of a histopathological thing. You cannot say that based on the tumor markers.
yes,
What else would that trigger if you had that kind of a tumor marker?
Yeah, if it's a high beta HCG, I would plan to do a MRI brain also, sir.
How high?
When it's more than 50,000, I will, as you told, it is more than 50,000, as you mentioned. Then I would like to do a MRI brain also to rule out brain mets.
Yeah. So now the guidelines are actually recommending it as 5,000, as more than 5,000 is what is recommended for beta HCG. Although I personally feel that that's too low a threshold for doing it, because that might trigger too many brain scans, which not really finding much. But anyways, you should, for your exam point of view, you should be knowing 5,000 as the cutoff.
Yes.
What else would trigger brain imaging? So beta HCG more than 5,000 is one thing. What else is going to trigger?
Multiple lung mets, sir. If it's a multiple lung mets, then I will be more towards triggering towards doing an MRI brain.
Right. What else?
Then is a diagnosed case of choriocarcinoma.
Yeah. So of course, a choriocarcinoma, beta HCG very high, extensive lung mets, or symptoms related to brain mets.
Yes.
Those are the indications for doing it. Okay. Now say this AFP was the same, 1.39.
Yes.
The beta HCG was say 750, and the LDH was also the same, 1053.
Then I will think of it is a it's mostly a non-seminomatous tumor only, sir. But
what makes you think so that it's a non-seminomatous?
One is beta HCG is elevated.
Okay.
As you told, it is more. It is 700. Mostly, I will be thinking of non-seminomatous tumor only. But my thinking is AFP is normal. Then the patient might have some seminomatous component also.
Okay. So you believe that if the beta HCG is elevated, then it cannot be a seminoma.
Yes. Yes, sir.
Anybody else would like to comment on that? Okay. Yeah. So we've got say 15% of seminomas which have got can elevate the beta HCG. It's just that there is that generally the beta HCG which would be raised would be in the ranges of 500, so say 1,000, 1,500 that kind of range. So in those few patients of seminoma in which the isolated beta HCG, isolated means LDH can be elevated, but AFP is normal. But if there's an isolated beta HCG elevation, it does not rule out the possibility of seminoma. In fact, it's more in favor of that. It's just that if this elevation is in thousands, like if you got say a beta HCG of 5,000 or more than that, and that's something which may not happen in very often in these 15% cases of seminoma. But otherwise, it is still compatible with seminoma.
Okay.
Right. So you've got these 3 tumor markers, and then do we have images of the scan, the CT scan?
Yes, sir. We have the images, sir. Please go. Sir, are you able to see the DICOM images?
Yes. You've got a very friendly chat box with all answers popping up over there.
Yes.
You'll have to be honest to keep the chat box off, or otherwise I'll have to request others not to give those answers.
So I'm able to see a non-heterogeneous mass in the left iliac region.
There's more. Right.
This is
You, yeah.
testicular mass.
Yeah. Can you run that again from the chest onwards? We didn't find anything in the chest, no?
No, sir. There is no findings in the chest, sir. There are apparently looks normal. No gross retroperitoneal lymph node, no gross retroperitoneal lymphadenopathy.
Okay.
We have seen some left in the left common iliac and external internal iliac. We have some lesions, sir.
Yes.
And we have left testicular swelling, which opposite side testis looks apparently normal, with mild specks of calcifications and heterogeneous lesion.
If you're really interested in talking about the scrotal mass, then what are you looking for in the scan? I mean, what are you more interested in?
One is already this patient was operated. When I would see there is breaches there or not, means skin involvement is there or not. One is in the this thing, and you see the opposite side of the testis, whether it is normal or not.
Okay. When would you want to image particularly for the scrotum? I mean, like a cross-sectional imaging or a CT scan or an MRI?
So when there is a very small lesion which is of less than 2 centimeters, or less than 1 centimeter, solid lesion, then
Yeah.
I like to do a cross-sectional imaging or a good ultrasonography.
Because you want to plan a
we have planned whether we have to do an IML orchidectomy or a Chavasus maneuver.
Yeah, so Shivas's maneuver is one thing. Otherwise, typically when you are planning to do something called as testicular sparing surgery or TSS, that's when you would want to quantify this lesion better on a cross-sectional imaging.
Yes.
And yes, as you said, it's generally for tumors less than 2 centimeters and unifocal lesions. That's when, and particularly in patients who've got a solitary testis or bilateral tumors, that's when you have to do that kind of an evaluation. But I think in this patient, what you're more interested in looking is that what's the proximal extent of the tumor on the scan. I mean, your diagnosis is glaring. There's nothing else that you want the diagnosis.
Yes.
From the point of view of saying that this is a testicular cancer.
Yes.
You have the markers which are pointing out towards it being a seminoma.
Yes.
But what I'm saying is that in your exam, you should be knowing on what things to focus on and emphasize more time, when you are describing the scan. Right. So in this patient, I don't think you need to spend too much of time describing the testicular lesion unless you are focusing on the fact that it is involving the cord, or you are, say you're going to expect any difficulties in ligating the cord at the level of the deep ring 1 ring because the tumor is reaching all the way up to that point.
Yes.
But otherwise, I think your focus should largely be on the tumor, on the retroperitoneum and the pelvic nodes. That's one.
Yes.
What else do you want to comment on the scan? So while in this patient, it being a seminoma, possibly the role of surgery is going to be lesser. But let's presume that this is a non-seminomatous tumor. Let's say that the AFP was 500 in this patient, and you have the same kind of a scan. So one is you've got the disease burden, I mean, as in location of tumor that you mentioned. What else do you want to look for or kind of comment on?
One is the size of the nodes, retroperitoneal lymph nodes. What is the size I want to know?
Okay.
Because to stage the disease, I want to know the size of the nodes.
Okay, which in this case is?
And next is after doing the so you're asking about after high inguinal orchidectomy or before the treatment, sir.
Okay, and fine. So what is, have you staged the disease over here so far based on the scan findings and all?
Yes, sir. It's looking based on the scan findings. It's a more than a 2 centimeter node is present, sir, in the iliac region. Most probably it might be an N2 disease, and the tumor marker LDH is elevated 3 times. Most probably it will be the S1 tumor stage, and N2 and S1, sir. As I did not did any high inguinal orchidectomy, I'm not known whether it is an the T staging.
So I don't know, but is this like a 2 centimeter disease that we're showing?
Sir,
I mean, if you, do we have coronal and SAG as well for this patient?
yes, sir.
Do you want to also open up the staging, or do you remember it for testicular cancer?
Yes, I remember, sir.
Is he like heavily constipated, this guy? What's it? Why is the colon so loaded? And by the way, when you're describing your scans of these patients who may or may not be candidates for RPLNDs later on, that's where the disease is starting. And it's a sizable thing here. I don't think it's 2 centimeters. I think it's probably, I mean, if you look at the, along all the axes, and if you look at the number of nodes and the locations, it probably would be more than that.
Yes.
Anyways, the other things that you need to describe on these scans, even if it's a negative finding, is that whether there is any presence of a hydroureter or hydronephrosis or no, because you know, that's common to see with these tumors.
Yes.
You would also want to describe accessory or aberrant vessels in the scan, which is because, you know, there's a possibility you are going to require an RPLND in this patient if it was a non-seminomatous germ cell tumor. And it's important to know, particularly if there are any accessory renal arteries or any aberrant vessels, you know, retrovertic renal veins and those kind of things. You have described that the kidneys otherwise are looking fine. Sometimes you are able to see vertebral metastasis in these scans in testicle. It's very rare to find them, but you can at least, you can mention that the bones are looking normal.
Yes.
Yes, so there is actually an interesting thing over here, question over here in the chat box, and I think I had the same in mind. That considering that this is a pelvic node,
Yes.
would you want to call it an M1 disease?
No, sir. I don't want to call it as an M1 disease. Except for if I as the patient is also having the inguinal nodes.
Yeah.
If that inguinal node in ultrasound is suspicious, or ultrasound guide FNAC shows some cells, carcinoma cells, then I will feel that it is an M1A disease.
Yeah, but again, you know, they've got no business to be having inguinal nodes in testicular cancer patients unless there is what?
Scrotal violations.
Okay, and what all is called as scrotal violation? This patient has or no?
Yes, sir. It's open, sir. The testis is open. There's a scrotal violation.
What all constitutes a scrotal violation, and why is it important? Why are you worried about it?
Because the scrotum is violated, there will be no pattern of regular pattern of lymph nodal spread will not be there.
Okay.
So there might be inguinal nodes, and there will be inguinal nodes will be there, and there will be a
So yeah, so you
retrograde
one
spread will be there.
So one is that you would expect altered spread of the disease. That's one. Oncologically, how does it make a difference?
Oncologically, it will be like if it is scrotal violation is done, it will be more. We have to do a scar excision also, sir. And next is it will be non-regional lymph nodes is possible. Then it will become under M1A disease.
Why do you want to do the scar excision?
Because the seedling of the tumor cells will be seen.
Huh?
So I want to do a scar excision, or seedling of the tumor cells will be seen, sir.
No, so basically when you talk about oncology, I mean, whenever this question comes up in your exams for a particular thing, you should be talking about whether it is going to increase the chances of a local or a distant disease or recurrence, or whether it is going to have an impact on the survival at all.
Yes.
Okay, so what constitutes a scrotal violation is typically if you have either a transscrotal surgery, or if there's been, say, a hernia surgery which has happened in the past, or sometimes a biopsy, which is a very crude biopsy, is considered a scrotal violation.
Yes.
FNAC is generally not considered a scrotal violation. In fact, we do FNACs a lot of times in our patients, particularly when there is a doubt about a hematolymphoid malignancy versus versus testicular cancer, because lymphoma and testicular cancers can sometimes happen in the same age group of patients. It can have the same kind of presentation with retroperitoneal nodes and testicular involvement. Or if there is a lesion which is not, which is confined within the testis, and the architecture of the testis or the lesion as seen on the sonography is not very unequivocal, then it is okay to do an FNAC in these patients. If the FNAC is not helping, then of course Shivasus is what you do. Now the issue with scrotal violation is that whatever retrospective series are there have said that it increases the chances of a local recurrence, right? But it doesn't alter the overall survival. It doesn't alter the chances of distant disease. It is preferable to do a control locally, particularly in patients in whom a further systemic therapy is not planned. So if a further systemic therapy is planned, then the chances of these local recurrences also come down. So if, say, this patient is a seminoma patient, then he is likely to require chemotherapy after this. He's likely to require radiotherapy after this. But because it's not really too much of a surgical, not really going to add too much of a surgical morbidity. Say this patient, actually, the scrotum, I mean, they had closed, they have not removed the testis, but most of the times what will happen is that they'll do a scrotal orchidectomy and the cord is remaining. And it's generally this cord that you would prefer to remove when you're doing an RPLND in these patients later on, and you would want to revise the scar. There was a time when a hemiscrotal excision was advised for a scrotal violation, but that has been given way. It is known that that's an overkill that is probably not required.
Yes.
Right. So anyway, so now you have this patient, and it's actually unusual to find this kind of a nodal pattern.
Yes.
I would have been otherwise tempted to go back to the patient and ask if there were actually any surgeries in the past, or if there is like a hernia surgery congenitally that has been done, various other things which could explain this pattern of disease spread. Right. So you have this patient, and he has seminoma, and he's got primarily a pelvic disease and no chest disease. how do you want to risk stratify this patient, and what kind of tool do you want to use for risk stratifying?
GCC is risk satisfaction attribute, sir. Whether it's a good risk or an intermediate risk. If a good risk is defined as any primary site with no non-visible metastasis, no non-pulmonary visible metastasis. Then it's called as good risk. And the intermediate risk is with non-pulmonary visible metastasis. And there is no poor risk in seminoma, sir.
Yeah, okay. And if it was a non-seminomatous germ cell tumor, then you would also have an additional poor risk category, which would also include all medicinal disease as well.
S3 disease.
Yeah. So this patient is going to fall under good risk.
Good risk, yes.
Okay. And what do you want to plan for this patient now? And what's the final stage that you're giving to this patient? Do you want to see this? Do you want to see the staging once before you actually finalize this? Because generally, I mean, even from your exam point of view, I would suggest that testicular cancer staging is a little tricky because it's confusing, it's elaborate, and also unless you are used to using it very routinely on a daily basis, you're bound to get confused on it. And also with subtle changes in the stage, even between like the ABCs, they could be change in the treatment management.
Yes.
So for testicular cancer patients, I mean, if you're going to make a list of the last set of things that you want to read one day before the exam, I would suggest keep this as one of them.
Yes, a CT scan is showing
you are able to smuggle some chits inside their exam halls. Yeah.
A CT scan is showing it is a more than a 5 centimeter lymph nodal mass.
Yes.
And the tumor markers are in the S1 range, as it is LDH is about 2 to 3 times elevated. So it come under it is come under N3 disease and S1. So most probably it is come under 3B, sir.
Okay, fine. So that actually sounds better. And good risk, you said?
If it is a seminoma, sir, as I have not done any high inguinal orchidectomy. If it is a seminoma, then I will consider it as a good risk. If it is a non-seminomatous, then I will consider it as an intermediate risk.
Okay. And I can see some PET scan is there for this patient. Why was a PET scan done?
No, sir, it was done. His patient came with the PET scan to a hospital OPD with the surgery and the PET scan.
Okay.
But there is no role of initial PET scan in the testicular tumor, sir. Okay.
When is there a role?
Sir, there is only role in the case of seminoma. After giving a chemotherapy, if it is a residual mass is more than 3 centimeters, I want to know whether it is a activity is there or not, sir. Because whether it is a fibrotic mass or a non-fibrotic mass.
Okay, we'll come there. We'll come there later on. Anyway, so this patient, I mean, otherwise, be very sure that there's no role for a PET scan at this stage, whether it is a seminoma or whether it is a non-seminomatous germ cell tumor.
Yes.
How do you want to proceed with this patient? So you said it is what, 2C?
No, sir, 3B, sir.
Okay, and why do you call it a 3B?
Because he's having because I want to know the status of the inguinal node, sir. If this inguinal node is a positive node, then it will come under M1A disease, and then directly will go into the 3C. If this inguinal node is negative, as his range is in the size is more than 5 centimeters, and the tumor marker is in the S2 range, then it will come under the 3B disease.
Okay, tumor markers are S2.
No, sir. Yes, sir. S2. Yes, sir.
Okay, because of the LDH.
LDH.
Okay, fine. Right. Now, how do you want to proceed with this?
Sir, I want to give chemotherapy, sir. First to the disease, that is bleomycin, etoposide, and cisplatin. Before that chemotherapy, I want to see the lung status by doing a pulmonary function test and DLCO.
Okay.
And all other routine investigations like 2D echo and all other this before creatinine clearance before giving chemotherapy.
So there are a couple of questions about here. We will stage only hydroxyctomy. Yes, that is generally true actually. And with scrotal violation history with inguinal and pelvic disease be considered an M1. So I think in this patient actually the scrotal violation has happened too soon. There's hardly just 2 weeks gap actually. So I don't think the distribution of disease is something which would be explainable by that scrotal violation, that within 2 weeks suddenly these nodes have come up. And I doubt whether that inguinal node which you are mentioning is also, I mean, you can always do an FNAC of that node. I don't know whether it's been done or no, but so to consider that because there's scrotal violation 2 weeks back, that's why they've got an inguinal node and you've got such a big pelvic mass in this patient. I don't think that is something which we can explain.
Yes.
So you bleomycin for your bleomycin you want to do the pulmonary function and see for this patient.
Yes,
okay, fine. That's one thing which you should be doing. What else do you want to do before starting your chemo?
So as a young gentleman, which is 17-year-old gentleman, an unmarried boy. I will do a semen analysis for this patient, sir. Because if we give chemotherapy, there will be alteration. And if planning, I will do a cryopreservation or sperm banking for this patient.
So say this patient is a well-read and well-googled kid, Actually, what would you want to call him? You would want to call him a child, you would want to call him an adult, or anything else that you would want to categorize him under?
There is 17-year-old, sir. He is called as adult only, sir. Less than 14.
Adult, okay. Anything else? Any other newer, fancier term which might get you some distinction marks actually?
Young boy.
Yeah.
Young
adult. Okay, yeah. So anything, yeah. So see, I think Ramya has been trying to help you all through. You should just keep on following her replies on the chat box. So yeah, AYA is a term that has been used, these days for these patients. I'm not sure what the definition is. I think 17 comes under AYA. So adolescents and young adults. The reason that this is a separate category is because they have their own set of issues, and these issues are not just short term during the treatment, but also long term, because a lot of these cancers patients are going to survive longer and they have their own quality of life issues which has to be tackled accordingly. So AYA, in fact, high volume centers would have AYA clinics separately, where these patients are kind of counseled and managed for long term. Now, so coming to this patient who's say otherwise well read and well googled, and he is going to ask you that why do you want me to do this sperm banking? I mean, I'm really stressed about my cancer at this point of time, and you're sending me for collecting my semen. He's not convinced.
Sir, if normally, sir, if we given like chemotherapy for 3 to 4 cycles, it might come. The counts may come normal after at least for it will take at least 3 to 4 months to coming back to normal if it comes.
3 to 4 months.
Sorry, sir. It's like 8 weeks, 8 weeks to 12, 4 to 8 weeks, sir.
Okay. No, it's almost, somewhere between 2 to 3 years. So it's at least 3 years. I mean, once there is a damage done to, the sperm count, it will take at least 3 years for them to come back. Do all of them come back to normal?
No, sir.
Okay.
So I want to explain all these things to the patient that if the
Huh.
sperm does not come back,
So basically, you have to tell him that a quarter of patients, around 20 to 25% of patients, the damage is irreversible and you may not uh, get your sperm count to normal. What else? And why is this happening actually? Because of which drug?
like I'm not sure, sir.
It's because of the platinum, no?
Yes, sir.
Yeah. So they are the ones which are the most toxic to the sperms. Now, so one is that there could be a possibility that they may not revert back, and the second is that we don't know what his baseline, testicular function is. So what we know is that in testicular cancer patients, almost around 20 to 25% of them would have a baseline oligospermia, a baseline azoospermia, in fact, and an additional 20 to 25% of patients could have a baseline oligospermia. Which is going to go further down after the chemotherapy is given, and that is the reason that a sperm banking is advocated before the treatment is initiated. When do you want to do it actually? Before orchidectomy, after orchidectomy, before chemo, during chemo?
No, sir. Before starting chemo, I want to do it, sir.
Okay, not before orchidectomy.
No, sir.
No. Why? When is the best time to do it actually? So, generally it's true that the maximum toxicity is because of the chemotherapy, and so it has to be done. There's no point doing it after the chemo started. But there have been studies which have tried to look at the semen parameters before and after orchidectomy, and they found that actually after orchidectomy also there is a dip in the parameters. So the best time to do it is before orchidectomy. But if for some reason the patient is not able to do it before orchidectomy, then the next best time is before the chemotherapy.
Okay, sir.
Yeah. And if the patient is, say he says that he's extremely stressed out and he's not able to, ejaculate by himself, then
intracytoplasmic.
Are there any other options? Yeah. So basically, TISA, I mean, basically testicular aspiration is something which can be done and frozen. I don't know if there are any audience has any urology people also, or they're all surgical oncology. Okay. Electrical penile stimulation. Oh, what some really fancy things there. Kushal. Is Kushal a urologist or a surgical oncologist? Anyways, yeah, electroejaculation is the right term which is to be used, but that's generally reserved for those who have an retrograde ejaculation. But over here, I think if a direct aspiration from the testis is something which can be done. In fact, there's now a concept called oncotisa, where if the testis is not completely replaced by the tumor, then even from the testis which is being removed, you can aspirate or take a biopsy and freeze some of the testicular tissue. Actually, I mean, it's oncologically considered to be largely safe to be considered. Right. So that's the fertility bit. You started the patient on BEP.
Yes.
He was found to be fit for BEP, and you started the patient of BEP. How many cycles do you want to give?
As this is if it is a 3B, 3C disease, I will give you 3 to 4 cycles of BEP, sir.
3 to 4, 3 or 4.
4 cycles of BEP, sir.
Okay, fine. And once you have given that 4 cycles of BEP,
yes, sir.
what else do you want to do? Then what do you want to do?
Then I will ask the patient to come at after 12 weeks, 8 to 12 weeks, sir, to do serum tumor markers
Okay.
and to do CECD chest, abdomen, and pelvis.
Okay.
If it is a seminoma, then I will do a PET CT. If it is not non-seminoma, I will do a CECD chest, abdomen, and pelvis.
Yeah. Okay. So I think what's important over here is that you have to wait, particularly if you have a diagnosis of seminoma. Do you want to do the orchidectomy before giving the chemotherapy in this patient, or you started with the chemotherapy first?
No, sir. I will do first high inguinal orchidectomy before starting the chemotherapy.
So when this patient had the scrotum opened in Jharkhand, right?
Yes, sir.
So they had taken a biopsy, or they had not taken a biopsy?
They have not taken any biopsy, sir. Just they have given the incision, they have opened it, telling that the patient is having some benign thing. They have not done anything. They have closed it and they have sent it.
Okay, fine. So you want to do a high inguinal orchidectomy first for this patient?
Yes, sir.
Which would be accompanied by the scrotal scar revision.
Yes, sir.
And has that been done?
Yes, sir. It has been done, sir. 2 days back only it has been done.
Okay. And what did that turn out to be? We are still waiting for the pathology?
Yes, sir. We are still waiting for the histopath. 2 days back it was done, sir.
Okay. Okay, fine. Do you always want to do a high inguinal orchidectomy in these patients?
Yes, sir. If the testis is removed completely, then we can wait and we can do a scar excision or hemisplenectomy. But if testis is not removed or we will not get any diagnosis, then better to do a high inguinal orchidectomy.
Okay, say if this patient's alpha beta protein was 2000 and beta HCG was 3000.
In special circumstances, if patient is having severe lung mets and high tumor markers with high symptoms, then I can directly start with the chemotherapy.
Yes. So basically, if there is any indication of there being a very large tumor burden, which could either be an indication based on the symptoms, or it could be an indication based on the markers which are very high, or it could be an indication based on the radiological findings which show an extensive disease, then one could consider an early upfront chemotherapy, obviously presuming that the diagnosis is an equivocal one. The whole reason for doing an orchidectomy first is, one, because you want to stage the disease properly, and the second is because it was always considered that there is a blood testis barrier which wouldn't let chemotherapy reach the testis. Now, while this is largely true, but often the kind of patients that we see over here, the testicular masses are so big that the blood testis barrier doesn't exist anymore, actually. And in fact, one of our studies, we were able to prove that in patients who had an orchidectomy done after the chemotherapy, more than 50% of them had response seen in the testis also. So the chemotherapy had actually gone into the testis and there was no disease seen in the testis after it was removed after chemotherapy. Anyways, so yeah, so this patient, you've done a high inguinal orchidectomy. Let's consider both scenarios. So say if this patient has got the high inguinal orchidectomy turns out to be seminoma, then what is your plan? If it turns out to be non-seminomatous, then what is your plan?
If it is a seminoma, then I will see the histopath report and as already the CT scan is showing N3 disease and H2 elevated tumor markers. Mostly the management like chemotherapy regimen and the chemotherapy cycles will not change, whether it is a non-seminomatous or seminomatous, as the patient is having N3 disease.
Yeah.
Most probably it will not change. It is a stage 3B disease.
Yeah.
But after doing a high inguinal orchidectomy, I will wait for 4 half-lives for the serum tumor markers to come down. And after say about after 4 weeks, I will repeat the serum tumor markers.
Okay, fine. So there's a little bit of a difference over here. So say you've done a very good hyogonal orchidectomy, and the patient goes home the next day, and 3 days later the patient comes back that he's absolutely fine. The drain is removed, they were absorbable sutures, and the patient looks fit for starting chemotherapy.
Yes, sir.
Are you going to send the patient back home saying कि नहीं 4 हफ्ते के बाद आना because I want to check your tumor markers and only then I will start you chemotherapy?
So I'm not pretty sure.
Okay, so yeah, so while this whole definition of staging the disease does hold true, saying that the nadir should be reached, and that would be important in staging the disease, but it should not be at the cost of delaying the treatment if it can be started, right?
Yes, sir.
And depending on what the markers were to start with, you will obviously have a trend of what is happening in one half-life, okay, which is how much? Half-life for AFP and beta HCG?
Yes, sir. Half-life
Quickly,
for AFP is 5 to 7 days, beta HCG is 24 to 36 hours.
Yeah, so you could just, for exams, you could just remember 1 week and 1 day, right? Close to that.
Yes.
But essentially what I'm saying is that if there's a patient in whom the markers are declining actually, then, and the patient is otherwise fit for receiving the chemo after the hyogonal orchidectomy, then what you do is that you consider the tumor markers which are there at the time when you're starting the chemotherapy. You don't have to necessarily wait and delay the chemotherapy just because you think that this staging has to be done, because it's not going to change the it's not going to change the management or the schedule of chemotherapy otherwise. That's something which is more of a practical tip, because you may or may not get this in the literatures per se.
Yes.
Right. Okay, so you've given that chemotherapy,
Yes, sir.
and 4 to 6 later, or 6 to 8 weeks later, if it's turned out to be seminoma, then you do a PET scan. What on the PET scan is going to trigger you to treat this patient further, and when can you observe?
Sir, in the PET scan, if the tumor, if the size of the lymph node mass is more than 3 centimeters and PET scan is showing some activity.
You are going to do the PET only if it is more than 3 centimeters.
Yes, sir, if there is an activity,
if it is less, if it is less than 3, you won't be doing a PET.
Yes.
What if it is less than 2 centimeters?
Is it a seminoma, sir? In seminoma?
Yeah.
Then I'll wait, sir. If it's less than 2 centimeters, I will observe.
If it is less than 2 centimeters in a non-seminoma?
No, sir. I will operate, sir.
Straight away? You completed your chemo.
Yes, sir.
It's been for 6 weeks, 6 to 8 weeks, and then you have something like less than 2 centimeters lesion, maybe a single node seen. The patient has non-seminomatous germ cell tumors. The markers had normalized after the orchidectomy and chemo.
If possible, I will do a guided FNAC to confirm it. And mostly,
No. So
I will do the surgery, sir. If it is more than 1 centimeter, I will do the surgery.
Yeah. So generally for retroperitoneal masses in testicular cancer, avoid doing FNACs and biopsies. Most of the times it is not required and not recommended because it has a lot of fallacies.
Yes.
Very, very few selected scenarios when you want to do it. Now, if it is less than 2 centimeters at the first scan after the chemotherapy, and it's just a single node less than 2 centimeters, there's still a place of waiting for another 6 weeks to see what this node is turning out to be. If at 6 week scan, again, it turns out to be the 2 centimeters one, then you have to go ahead with a RPLND. If it turns out that it has actually dropped down in size further, because sometimes it so happens that the effect of the chemo takes a little longer, and in some of these patients, you might be able to see a further decline in the size of the mass to less than 1 centimeter, which is generally the threshold for doing an RPLND. And if it is the same or it is increasing, obviously you have to do an RPLND. If it's a seminomatous tumor, then based on the PET scan, you are going to decide. If it is more than 3 centimeters and if it is avid, then you would send them to your radiation colleagues. And if it is more than 3 centimeters and
That is showing some.
it is not showing avidity, and if it's like totally cold, then you probably can observe these masses. Or in that case, if you have any doubts based on other things, based on other radiological findings and such things, then you could consider doing biopsies of these set of masses. So where do you get this whole information about FDG and FDG PET scan and seminoma? I mean, do you want to quickly name the trial, because that's important?
So I'm not aware of that.
Okay. Anybody else wants to put it on the group? Okay, so while there is a name of a trial, but somebody's Saurabh is there. Huh? Saurabh, you're digging your own grave over here. So the trial which I was looking for is the SEMPET trial, actually. SEMPET is what had looked into the role of PET scan and find that it's got a high rate of high negative predictive value. So the PET scan says that there is no avid lesion, then it is very, very unlikely that there's any active disease and these patients can be observed. But the positive predictive value actually has been doubted in other series. Now, what Saurabh has mentioned is the Tiger trial, which I don't know if you want to discuss over here, but that's an ongoing trial. And it's actually about salvage chemotherapy. So I don't think we'll go to that. Right now, what if this patient had non-somatomatous germ cell tumor and the repeat scan showed that the tumor was around 3 centimeters or so?
Then I will go ahead with the RPLND, sir.
Okay, then you'll go ahead with an RPLND. Is there any role of RPLNDs in seminoma?
So before. So after chemotherapy, sir, or before chemotherapy? Before
any role. I mean, just tell me, if I had to ask you the indications of doing an RPLND in seminoma, when all can you consider or you should consider doing it?
So if it is more than 3 centimeter lesion after chemotherapy, residual mass more than 3 centimeters, if the FDG activity is present, more than 3 centimeters, then I will go for an RPLND in seminoma.
Then why you planning for, in this patient, are you planning RPLND or radiotherapy? Or how do you take a call between RPLND and radiotherapy? I'm talking about seminoma. We are talking only about seminomas right now.
A single node which is
so there are two things which happened. One is that it was realized that when you do an RPLND for a post chemotherapy seminomatous mass, the desmoplastic reaction in them is so much that these RPLNDs have a higher morbidity than usual. Although these data come from earlier series when the techniques of RPLNDs were not that well evolved. The second thing was that there was a realization that seminomatous are highly radiosensitive tumors. So, if you look at the RPLND initial series of RPLNDs being done for post-chemo seminoma versus post-chemo non-seminomatous, then the recurrences or the in-field recurrences in seminomatous tumors were more, and there were higher rates of complications, and that is why RPLNDs were discouraged in seminoma. And with the parallel realization that these tumors are very radiosensitive, radiation became the main modality of treatment for patients in seminoma post chemotherapy. But if you are a high volume center where you are used to doing RPLNDs, and if the mass is a more well-defined one where radiologically it looks like it can be removed, then there is no contraindication to do surgery in these patients, these set of patients. You obviously don't have to be heroic in doing these surgeries because radiation is, the mainstay of treatment which is available. The other thing is the scenario where you have a stage 1 disease and these patients are chemo-naive, and you are considering between what are the options for stage 1 seminoma that you would want to discuss with patient?
One is observation, sir, surveillance.
Surveillance, yeah.
And next is one cycle of carboplatin or 2 cycles of carboplatin under AUC 7 curve.
Yes.
And another thing is we can do a radiation. We can do an RPLND.
Yeah. So now sparing RPLNDs in both stage 1 seminomas and stage 1 non-seminomatous is one of the options. But that's also an evidence which is kind of undergoing change recently. And from the surgical perspective, you could know about the SEMS trial actually, which is going on. It's called the SEMS trial. And essentially, they are kind of looking at the role of post-chemo or chemo-naive RPLND in seminoma at a higher stage also. I mean, even in stage, I think up to 2C, they are including patients. Fine. There's a question about, could you describe template of RPLND and what else is there? Can we say that we choose RPLND in post-chemo seminoma or RT as it will not be possible to go out to our RPLND post-CT-RT? Ronak, so it's generally doing an RPLND after CT most of the times is not required because these seminomas respond very well to radiotherapy if it has been well delivered. If the treatment was a compromised one, obviously then you can have recurrences. But the thing is that post chemotherapy, post radiation, it is very difficult to know about whether there is active disease. There's a possibility that you may see disease, some on the scan, but they may not be avid on the PET, or they may just be necrosis. But this kind of a scenario where you have to do a salvage RPLND after radiation in a seminoma is a very rare one. Can we? That's one. Yeah, could you describe the template for RPLND? Right. So, Sandeep, would you want to do that for me?
Yes, sir.
Or could you quickly tell me the kind of RPLNDs that you know of? If I ask you to, tell me about types of RPLNDs, yeah.
One is bilateral RPLND, sir. And is nerve sparing RPLND.
Okay.
And is unilateral template RPLND. And another is desperation.
Modified template.
And desperation RPLND.
Okay. And
next is bilateral nerve sparing RPLND.
Okay, fine. Yeah. What is desperation RPLND?
Desperation RPLND is when the resectable disease, when after giving a salvage chemotherapy also, if the nodes are there, if the residual lesions are there, if it is resectable, that is called as, will you do a desperation RPLND.
And what's the difference between a desperation and a salvage RPLND? What's the key thing required for calling it a desperation RPLND? So yeah, you've given salvage, so you had at least 2 lines of chemotherapy, but the markers are elevated.
Okay.
If the markers are elevated only, then you call it a desperation RPLND. Do you want to quickly tell about the templates, laterally, cranially, caudally? Actually, if we have time, I can show you a small video on RPLND.
Yes, sir.
But then we'll have to cut short this and then go. Yeah. Template.
The template is superiorly infrahilar, sir, and laterally uretus, and inferiorly up to the iliacs, common iliac, external interiliac.
Okay.
This is the full bilateral template for RPL.
Okay. 1 second. Huh?
Yes, sir.
Can I just quickly check for a video if I can show you?
Right. Yes, sir. We have to stop the screen share. How would you stop? Unko bol. Sir, I think I have to stop the screen share, sir. I will check it with that and I will stop the screen share.
Yeah, that's okay. Just give me a minute. I'm trying to find the video. Yeah, I'm just sharing my screen now. I hope it's all seen the screen.
Yes, sir. It seems.
Yeah. So yeah, this is something which we had recorded some time back. So you know, this is before you plan an RPLND. So chest, always look for two things. One is gliotoxicity, and you should be knowing the burden of the disease in the chest. We did not discuss about this, but I think somebody asked in the chat box about the extra retroperitoneal disease. So when we talk about discordance between the retroperitoneum and the chest, if you've got disease in both the compartments, and this patient did not have, but say if you've got disease in the retroperitoneum and the chest, the dictum is to go ahead and remove whatever disease is possible, because there's a considerable discordance between the retroperitoneum and the chest. And this discordance becomes all the more, these rates become all the more pronounced if a patient has already received salvage chemotherapy. So even if you do and say RPLND and find out that there's only necrosis, but there is residual disease in the chest, then you still have to go ahead and address the chest. The only time when you could probably not operate is if there's disease on bilateral chest and you've done on one side and found that there is no active disease or only necrosis, then maybe on the other side you could skip doing it. Alter anatomy, as I said, if there's a retrocaval, it's the anatomy of the tumor, if there's any retrocaval extension there. Vascular anomalies like accessory vessels that you have to see. Component of seminoma, because if that's more, you could be expecting the planes to be more, sticky and difficult compared to non-seminomatous, pure non-seminomatous ones. And sometimes you may require a ureteric stent to be placed in these patients, depending on how the compression of the ureter. And you have to look for thrombus, which could be extending into the cava, or it could be extending into the from the gonadal vein. Now, This is something which you have to, I mean, it's your personal choice, but have a good non-sticking bipolar, have a good retractor. Loops makes a difference, particularly if you're doing nerve sparing. Keep your vascular, things ready. Sponge on stick is important. Prolines and other vascular sutures are important. Sponge on stick is important because you don't want a scenario where you have a cava injury and you have to put in your thumb to or a finger to plug it. So typically this is how it is. You have a mass like this which is seen, and it's a good idea to kind of compartmentalize it, or as I call the splits before you roll. So this is a paracaval compartment which is between the right renal vein and over here the common iliac artery. Then you've got the interaortic caval compartment which is between the left renal vein and the right common iliac artery. Then you've got the para-aortic mass, which is between the left renal vein and the IMA. And then you've got a compartment between the IMA and the left common iliac artery. And then finally, you've got a small bit of tissue, but a very notorious zone because the left common iliac vein is there between the iliac bifurcation. And your instruments, so whether it's a mixture diathermy dissection, a good non-sticking bipolar, energy sources, sometimes you have to use your hand, and I prefer to use the backside of the 50 number blade sometimes for these dissections. So this particular video, the first thing of course is packing of the mobilized bowel, and you see how bowel is well mobilized, gives you a good exposure. How do you know that the exposure is good? So, this is how, when your Thompson's has been well placed, if you have to stand like this, bending to see the renal veins, then your exposure is not good. You should be standing straight and be able to see your renal veins. So the first thing that you would start your template from is the ureters. So, that's the right ureter you can see over here. I hope I'm audible.
Yes, sir.
Yeah, and the video is not, it's playing well.
Yes, sir.
Yeah, so that's the right ureter, which is crossing the right common iliac artery. Right common iliac artery is probably the safest zone to start your dissection. So once you've seen the right common iliac artery, you walk up on it till you reach the bifurcation of the aorta. And most of the times the disease is not there in this area. So this is a relatively virgin area to start your dissection from. And as you ascend up, you see the IMA, and it's a good idea to identify the IMA origin and keep it, because it could otherwise be one of the sites of injury. For the para-aortic dissection, I generally prefer to use the bipolar. Once your IMA has been identified and kept separately, looped, then the para-aortic can be started. The next, you go to the left common iliac artery. Again, you start from a little caudal part of the left common iliac artery, and then start walking up, ascending up on the aorta. So again, we are coming on the same area, which is the para-aortic area, right? This is the left common iliac vein. This is the area. So generally, the left common iliac vein pops up much sooner than what you would think, and it is a common site of injury. So you have to be careful over there. Inferior mesenteric vein, because this is a largely para-aortic tumor, so you have to do that dissection between the para-aortic tumor and the inferior mesenteric vein and get it off the vein. Now you come to the cranial extent of the tumor, which is actually at the renal vein. So you can see this is the left renal vein. This is a site notorious for the lymphatics, so always use ligatures and clips over there. And then you lift off the mass of the psoas muscle. And this is also the area from where you can actually sometimes go to the sympathetic trunk, which could have consequences like postural hypertension in the post-op period if you've injured the trunk over there. That's the mass coming out. Then you go to the other part of the template, which is over here. This is the interaortocaval region. That's, on the cava, I find this reverse side of the 15 number blade to be a good dissecting instrument. It gives you the plane between the cava and the mass very well. And that's the interaortic cable region. So once you dissected the mass from the aorta and from the cava, both sides, then you have to go up to the prevertebral fascia over here and lift the mass off it. And in the interaortic cable region, again, that's a common site for a lot of lymphatics and chyle as well. So you have to use clips generously over there. Okay. And then finally, this is the paracaval region, where you're going to get some lumbars on both the sides. And you go up to the psoas muscle on this side, keeping the ureter laterally, and then lift it off all the nodal tissue between the ureter laterally, the cava medially, and the psoas muscle below. And retrocaval is something which, because in RPLNDs often you have retrocaval tissue. Depending on the side of the tumor, you'll have to remove the gonadal. So this side is the left side tumor. So we're removing the left gonadal completely. Yeah, so that's a template. That's the cranial extent. You can see both the renal veins. You can see the cava and the retrocaval tissue. Yeah. Okay. So I think I'll be winding up now. If you have any questions based on the case or other queries, then you can probably mail me.
Yes.
Sandeep,
Yes, sir.
am I audible?
Yes, sir.
Yeah. So if you want to continue further on different cases on testicular cancer, we can do it on some other
Yes.
day.
Yes, sir.
And for today's cases, if there are any queries, you can probably mail them to me. I think we have discussed most of the things related to the case that we had in hand today.
Yes.
Yeah. Okay. Is Sir also logged in? I couldn't see him.
Sir did not log in.
Okay. No problem.
Yes, sir. Sir is there, sir. Sir was there.
Oh, okay. I can't see. So, sir, good afternoon. This is Gagan here. I'm not sure. Anyway, Sandeep, we'll
Yes, sir.
wind up now.
Yes, sir.
Yeah. Okay. Thank you.
Thank you, sir.
Thank you.
So, sir came down.
Oh, okay.
Sir, thank you, sir. Sir was not there.
Okay. Sure. Thanks. Bye.
Thank you, sir. Thank you.